Hello, good evening, everyone. It's Dr. Angshuman. I am a senior consultant psychiatrist in Apollo Hospitals in Kolkata. And prior to coming to Kolkata, I was based in Manchester Infirmary. So today we'll be discussing the MRCP Part 1 of the psychiatry topic in our Farz Auxiliary Academy MRCP course. So thank you for joining us, and we hope it will be a useful session. May I kindly request all of you to please mute yourselves. Kindly mute all of you. Yeah? Thank you so much. Thank you. Okay. There will be a series of questions which you will have received, and we'll discuss the options and why the particular option is the correct response and what could be the associated questions. Question number 1 is, which one of the following metabolic disturbances would be a characteristic finding in a 20-year-old lady who is suffering from anorexia nervosa? Okay, so anorexia, will you have A, impaired glucose tolerance, B, increase in luteinizing hormones, that is LH levels, C, hyperkalemia, D, decrease in cortisol levels, and E, raised androgen levels? Okay, so these are your options, and the answer would be A, that's impaired glucose tolerance. So yeah, it's impaired glucose tolerance. So I'll tell you what happens. Just follow this up. So anorexia, as you know, is a BMI less than 17, and there is a body image disturbance. The person thinks the person is fat when she's actually, it's generally a she, but it can happen in a he, but mainly she. The girl seems that she's fat when she's actually very thin, like a stick, and she doesn't eat. She involves herself in various eating habits, but doesn't eat. If she at all eats, she vomits. Now, in this case, you have a decrease of everything. So remember this, you have low of everything. Okay, so your hyperkalemia will be actually hypokalemia, your androgen levels will be low, and rest of it, calcium, magnesium, everything will be low. The only thing that you have to remember is the cortisol levels are increased. Okay, the cortisol levels are increased and serum carotene levels are increased. And there is impaired glucose tolerance because in pancreatic alpha and beta cells, there are relationship between, the amount you eat and the glucagon levels in the pancreas. As a result, it varies. So your LH, FSH should be low. LH response will cause impaired LH-RH, is be hypokalemia, not hyperkalemia. Cortisols will be high, and you'll also have hypoalbuminemia, anemia, leukopenia. So everything will be down, as I said. Just remember, cortisol will be high, carotene will be high, and it will be impaired glucose tolerance. So that's your anorexia. Number 2 is a 36-year-old lady comes to A&E, accident and emergency department, complaining of swallowing difficulties for last 2 weeks. She reports that she feels a lump in her throat, and that is worse in the morning. There is no associated pain, and she had a steak sandwich for supper. Her family feels she has lost weight since her partner left her 8 months ago. On examination, the attending physician notes sweaty palms and tremor. She has a body mass index of 22 kg per meter square, which is the most anticipated diagnosis. Okay. A, anorexia nervosa, as she's not eating a lot, lost weight, that sort of thing. B, pheochromocytoma. C, globus hystericus. D, Barrett's esophagus. And E, hyperthyroidism. Yeah? Globus hystericus. It's actually quite straightforward. It's C, globus hystericus. Actually, globus hystericus is not a diagnosis. It's actually a feature. It's anxiety neurosis. Anxiety and panic disorder is your diagnosis. So if you have anxiety or panic as an option, you have to go for it. Globus hystericus is more of a symptom. It's a somatization symptom. That means you have a lump in the throat, and it's caused by hysteria. It's an old term. So globus hystericus, that's what it is called. So the answer is C. It's unlikely organic cause. She's able to swallow food, and there is no acid boluses, refluxes, so it's not a Barrett's esophagus. Hyperthyroidism, you have to have weight loss, sensation of fullness, tachycardia, tremor, all these things. And this weight loss is associated with lump in the throat. Anorexia is ruled out as BMI is 22. It's more than 17. Pheochromocytoma, again something. It's an adrenal tumor, as you know, causes weight loss, sweating, tremor. But we will have palpitations, anxiety, tachycardia, and of course, there'll be raised blood pressure. Globus hystericus is part of anxiety disorder and caused by a stressor, in this case, loss of a partner. The sensation is fluctuating and not a mechanical problem. So you have to take a good history. It's quite common actually in A&E and in OPD. You will find a lot of patients complaining of this feeling. You obviously have to have a thorough checkup. The ENT department is the first people who looks into it, but the examination finds no problem. And it's an anxiety disorder, globus hystericus. Okay. Someone has put something in chat. Right, nothing over there. Right, so number 3, which is the best example of a simple vocal tic that you see in Tourette syndrome? A, shouting obscenities. B, repeating same phrase over and over. C, premonitory sensations. D, teeth grinding. E, grunting. Yeah, the answer is E, grunting. So simple tic is just some noise. Shouting obscenities is coprolalia. It's a complex vocal tic. You sound, F words or other slangs, obscenities called coprolalia. Repeating same phrase over and over is called palilalia, repetition. And it's again complex phenomena, some words repeated. Premonitory sensations you get before a tic. It has nothing to do with a vocal tic. Teeth grinding is not a tic. As you know, it's bruxism in intestinal parasitic infestations or nighttime in night terror or something like that. The teeth grind. And E is grunting. So you have vocal tics like simple phrases or barking, grunting, sniffing, that sort of thing. So it's a part of Tourette syndrome. It's also associated with obsessions. So OCD, obsessional compulsive disorder, is associated with Tourette syndrome. And, tic disorder, Tourette syndrome, you treat with atypical antipsychotics, risperidone, haloperidol, things like that. And some behavioral therapy is also done. So that's your answer, T. E is vocal tics, simple tics, throat clearing, sniffing, barking, grunting, these type of things. Complex tics, as I said, are your coprolalia and stuff. Teeth grinding is not a tic. Okay, so Tourette syndrome. 4, 35-year-old gentleman lives alone, is brought to emergency department, escorted by the police. The police are called by a neighbor who noticed him applying silver foil to his windows. On presentation, he's agitated and aggressive. He's wearing a hat prepared from silver foil which it tells the attending physician is designed to stop transmission of thoughts inside his skull. That's very interesting. His past history reveals he attended emergency 3 times before, twice with issues of alcohol abuse, once after paracetamol overdose. Physical examination unremarkable, slim, looks disheveled, while the attending physician examining him tells the physician that the blood bottles are lined up in a way that means he will be put to sleep. So he tells this, which is the likely diagnosis. A, drug-induced psychosis. B, encephalitis. C, personality disorder. D, schizophrenia. And E, hypomania. Yeah, so this is a classical emergency setting. If you work in the UK in the A&E department, you will find these type of people. And there are obviously a diagnosis of exclusion or comorbidities. They might have 1 or 2 at the same time, but you have to look at what they're aiming at. So in this case, the diagnosis is D, that's schizophrenia. Why is it? See, when he says that he's wearing a hat prepared with silver foil that is designed to stop transmission of thoughts inside his skull. So that's something called thought insertion. In schizophrenia, there are 3 classical first-rank symptoms: thought insertion, thought withdrawal, and thought broadcast. If you find anything related to these, you diagnose it schizophrenia. The answer should be schizophrenia. They're looking at this answer because they have put this particular line. So your thoughts, you feel that someone is trying to get into your head, some thoughts are trying to get out of your head, and broadcast is your thoughts are known to other people through either internet or other ether waves or whatever. So it's very classical, this thought insertion thing. And the second thing is this blood bottles will lined up in a way that means that he will be put to sleep. This particular thing means delusional reference. That means he's saying something which doesn't mean. So blood bottles are arranged in a way. In emergency department, blood bottles will be arranged, but he puts a reason behind it. He thinks it is arranged in a way that he'll be put to sleep. So that's a delusional misinterpretation or delusional explanation he is giving. So that obviously is a schizophrenic sign. Okay. So schizophrenia is your answer, both thought insertion, delusion of reference. Okay, so you have to look into it. Alcohol and drug, obviously, you know, he has an history. So as I said, it could be a dual diagnosis. He could have alcohol misuse or drug misuse along with schizophrenia, but alcohol-induced psychosis won't be the correct diagnosis, or drug-induced psychosis. You have to put schizophrenia. Encephalitis is the organic thing. You have delusions, you have delirium, you have, altered sensorium. These things will happen, drowsiness, so that's encephalitis. Personality disorder is a vague term. You have lots of personality disorders and it doesn't fit the bill. Schizophrenia is your answer. Hypomania. Hypomania is milder form of mania, so elated behavior, fast speech, grandiosity, no sleep, that sort of thing. And it's not hypomania, it's schizophrenia. So that's your principal diagnosis. And there are markers. So remember, in your MRCP, whichever subject you answer, there will be few markers. So they have put those things for a reason. So you have to read the questions very well and try to find out what they're looking for. There are specific things. So in this line, they have mentioned many things, but they're wanting this thought insertion, delusion of reference. That's their most important thing they're trying to impress upon. Okay. So number 5, that's a 31-year-old gentleman with history of schizophrenia presents to a mental health clinic with the reoccurrence of auditory hallucinations following 8 weeks of non-adherence with his antipsychotic medication. He has no history of alcohol substance misuse, which is the best description of his auditory hallucination. So this is a straightforward theoretical question, really. It's not a sort of practical emergency question. It's a theoretical question. What is the auditory hallucination in schizophrenia? So A, is it external voice with quality of real perception? B, hearing a voice while waking up from sleep? C, hearing crying when in the shower? D, voice located in internal space saying you are pitiable? And E, hearing a voice on falling over to sleep. So these are the different voices you can hear, and they're trying to ask you which one is the best description for schizophrenia. So the answer is A. That's external voice with quality of a real perception. That's what is auditory hallucination. So it's clear, like I'm talking to you and someone with schizophrenia hears a voice exactly like this. So voice in external space, not inside his or her brain, external space with quality of real perception. So not a pseudo hallucination. So not broken, not hazy, not muffled, nothing like that. It's real voice and it's external space. Voice while waking up from sleep and going to sleep. Okay, these are called hypnopompic hallucination, and falling over to sleep is called hypnagogic hallucination. These are actually normal phenomena. These are not real hallucinations. You can have, voices or flashes of light or odd shadowy figures, anything like that, waking up or going over to sleep. Hearing crying whilst in shower, it's not a voice, it's a illusion. You're hearing something and misinterpreting. That's it. And the voice located internal space is not schizophrenia. You are pitiable, so that's more of a person who is low in confidence, who's got perhaps depression. So that sort of picture you are having. So answer is A. Auditory hallucination is located in external space and it is similar to quality like a real voice. So that's what you have to remember, and they're likely to be associated with impaired insight and reduced sense of voluntary control. So that means you can't control the external voice, you can't shut it off, you can't say, stop it or do anything about it. There are ways to stop in behavioral therapy, and obviously antipsychotic medication can be used. Okay. 6, it's a longish question. A 22-year-old undergraduate has returned to university after field trip to USA. The roommate has taken him to the health service as he has begun dressing in ceremonial robes and has announced to other friends that he's the dean of the faculty and orders his friends to wait on his every need. This is the vital line. And he also is known to use cannabis and ecstasy on other occasions. Additionally, he's been using some caffeine tablets to help him stay up in the night to prepare an essay for submission. And he has been suffering from worsening headaches over the past few weeks. The student health service persuades him to come for an urgent appointment, where on examination he's wearing a very bright colored shirt and trousers, black academic robe, and mortarboard hat. His blood pressure is 110/70, pulse rate is 80, and regular. Physical examination is unremarkable, but the examining physician identifies both pressure of speech and flight of ideas on mental state examination. Pressure of speech means speaks very fast and you can stop him in mid-sentence. Flight of ideas means it jumps from one topic to other. Investigation, hemoglobin is a bit low. Total leukocyte, platelets, sodium, potassium, creatinine are all okay. So what's your diagnosis? That's they're asking for. What's the likely diagnosis? A, personality disorder. B, schizophrenia. C, drug-induced psychosis. D, mania. E, intracerebral mass lesion. Okay. So the diagnosis is mania. Again, as I said, they're putting several things which you have to identify. So he has grandiose delusions. He thinks he's the dean of the faculty and his friends should wait his need. He's wearing bright shirts and trousers, an academic robe, and this pressure of speech, flight of ideas. These are all classical mania symptoms. Personality disorder, as I told you before, there are many types and it doesn't fit one particular one. Schizophrenia, no, he has a delusion, but it's not a schizophrenic presentation. It's more of mania because of the associated symptoms. Drug-induced psychosis, it's obviously one of your differentials. He uses cannabis, ecstasy, some caffeine tablets to help him stay awake. So as I said, like the previous question, there could be comorbidities, could be a dual diagnosis, but you have to put the, as you have only one option to choose, you have to go for the most vital and important one, that's mania. Intracerebral mass lesion, there is nothing, to say it has that. The worsening headache, they have just mentioned as a red herring type of thing. Obviously, in all these cases, we have to do a scan of brain and other blood workups, but it doesn't fit the bill of intracerebral mass lesion. So it's mania. So mania, it's a diagnosis. If it's a bipolar disorder, you could also go for it because simple mania or a single episode of mania doesn't occur on its own. The diagnosis is bipolar disorder, manic phase. And if they say mania, you have to go for it. So they're happy, elated, talks quickly, full of energy, grandiose, very self-important, they're easily distracted, irritable, delusional, lack of sleep. They're reckless, overspends money, and takes bad decisions. So that's it. You generally have to admit them. Use mood stabilizer, lithium, valproate, and carbamazepine are mood stabilizers. Along with it, generally atypical antipsychotics, olanzapine, risperidone, quetiapine, they are used, and benzodiazepines are used to help sedation and calming them down. So that's your answer. That's a classical picture of mania. Okay.